All right, I have about 30 minutes to talk to you about the novel oral anticoagulants. If you've got a TV and turned it on, you know about it. Does you or someone you love have a AFib not caused by a valvular condition? Or you can watch the old man shooting threes with his grandson. Up your game, 3 Eliquis, three reasons. You know, so the direct-to-consumer advertising of these things is everywhere, and they're pushing because frankly, the potential market for these anticoagulants is huge. And if you invent a new drug, what you want when you invent a new drug is you want a drug that they have to take forever. This sounds good. Anticoagulation, got AFib, you got to take it forever. And then that's one thing. You want the drug to have some advantages that patients like, so they don't need to be tested. They don't have to keep going to the anticoag clinic. They like that. You'd like other things that you can market for it, like they can eat broccoli and spinach now without screwing up their INRs. So there's no food interactions. I'll tell you all about that. And then they'll make the claim that it's actually better than the other drug. Even though none of the trials were to prove it was better, the trials were all non-inferiority trials. We'll talk about that in a moment. And they want to expand the market for these things to include ACS. In fact, if you go on the web and you download images to make a lecture, that's the kind of thing I do in my life, you'll find that they already have the ACS circle in there. And CHF, they want to expand into these other areas where anticoagulation might be a benefit. So these drugs are going to go everywhere. They're going to go fast. You can build a cogent argument that they're cheaper because the person doesn't have to take time off work, go and get tested and all this other stuff. The problem is that for us in emergency medicine, we have to clean up the feces. So there's a lot of feces here. So they're not reversible, at least not easily and not conveniently. So we see people who have trauma who are on these drugs. We see people with GI bleeds who are on these drugs. We see people who are post-procedural and have a retroperitoneal hematoma post-cath on these drugs. And now we're in a world where we can't even tell how anticoagulated they are because part of the feces is none of the tests to tell you that they're anticoagulated work. Plus, there's no information about overdoses. So when 3-year-old Johnny is found having gummed 9 tablets that are stuck to the coffee table, did he eat those or not? How many did he eat? There's like 3-4 tablet remnants and some drool on the coffee table. And so now you got to try and figure out, is this a problem? What do I do with that? No overdose data. So there's all kinds of feces that the emergency physicians are going to have to clean up surrounding this. So let's and I understand that if I start talking about, you remember in medical school, the intrinsic pathway, the extrinsic pathway, common final pathway, clot at my feet. Let's just briefly, without getting into too much detail of what I will refer to from here on out as the why. If you mess with the why, there will be a price to pay. Your body it turns out from an evolutionary standpoint, bleeding's kind of a bad thing. It means you've been wounded. It means the lions have got you or will get you. And so, bleeding is a bad thing. And so your body has to be able to turn on that clotting mechanism to stop bleeding. And it's a fairly powerful mechanism. And it also needs to turn it off and recanalize if you survive. And so right now in all of you, there's enough clotting factors to turn you into a bowl of Jell-O in about 30 seconds. And if you mess with the Y, anywhere on the Y, whether it's thrombolytics, whether it's recombinant factor 7A, whether it's heparin, whether it's warfarin, if you mess with the Y, there will be a relatively narrow therapeutic index. There will be a price to play. You'll either be too bleedy or too clotty. That's just how it is. The Y is finicky. So these drugs, yes, they're novel oral anticoagulants, but they sit squarely on the Y. So you have to know that anytime you're on the Y, you'll have a relatively narrow therapeutic index. And that's why drugs that are off the Y, like many of you have probably heard about tranexamic acid in trauma, for example. Tranexamic acid, it's over there. It's off the Y. And that's why when you look at the tranexamic acid safety trials, it's really good. If you look at the CRASH 2 data, safety data is excellent. It's not on the Y. You mess with the Y, you're going to pay. Now, the other things that we know about heparin and warfarin that are attractive about these drugs is that, if you want someone on warfarin, you have to start them on heparin and then bridge them. because they might form a clot in the middle. And so you don't have to bridge with these. So the good things about these, no food-drug interactions, no blood testing, no injections. They are currently approved for DVT prophylaxis, DVT treatment, PE treatment. The DVT market's pretty big. The PE market's not huge. Stroke prophylaxis and AFib, not due to a valvular condition, as you know from watching TV. Not for mechanical valves, not for ACS yet, but they want it to be. And so you're going to hear more about that. All of that, those indications would be considered sort of level of evidence B. But the bad news, no antidotes, and testing about these is not very, you can't really test for them. We're going to get into some of the sticky pharmacodynamics and kinetics of these things in a moment. So paper one, let's jump into the papers. It's the dabigatran paper. It's a 2011 update by the American Heart Association. It's basically a restatement of what abstract 2 is. They both talk about the same data. So abstract 2 is the data where dabigatran was first tested. So dabigatran is, and there's a lot of echo in here. Dabigatran is a direct thrombin 2A inhibitor on the Y. And the half-life of the drug's about 12 hours, and it decreases the rate of stroke for patients. It's 1.7% stroke rate on warfarin and a 1.5 or 1.1% stroke rate on Pradaxa or dabigatran, and the major bleed complication rates are sort of similar. So it looks like in terms of a non-inferiority trial, that's what this was. The RELY trial was abstract 2. It's a non-inferiority trial by Boehringer Ingelheim. And they said, yep, this thing is great, no bridging needed. Immediate effects, peak in 2 hours, so you don't need the bridge. And it's renal eliminated, so you got to be careful in renal failure. The average age, if you look at these trials, of patients enrolled in them is like 65, 70. Some of them are even older than that. So you know you're going to have some renal insufficiency in that population. And they were, in the trials, extremely careful about this. You can imagine when you then let the drug go loose, free range, among the AFib community with people prescribing, that ain't going to be the case. So when you talk about this renal elimination, if any of these people have worsening renal function, they're going to become over-anticoagulated, they're going to have bleeding problems. That's a little bit of feces we're going to need to clean up. So that's a problem that's out there with these. What's the cost of dabigatran? It's $5.45 for a 150 milligram capsule versus 47 cents for warfarin. So it's expensive, but not that additional cost goes away when you figure out lost time at work, going for the testing to see what your levels are, et cetera, et cetera, et cetera. So they know they have a winner and could charge for it. And that's the average wholesale price, the AWP. So just a little aside about the AWP, it's also called the Red Book. It's also known by those in the pharmaceutical industry as the ain't what's paid price. Because while there's an average wholesale price, there's tremendous variation. There's programs to support you with purchase. There's rebates and all kinds of things. But just to give you a ballpark, it's about 10 times more expensive. Now, the RELY trial is an interesting trial. That's abstract 2 again. It had, and you're going to see this number, it had 18,000 patients in it with non-valvular AFib. What does it mean to you when you're a reader, consumer of a literature like this, that Boehringer Ingelheim enrolled 18,000 people? It means the differences are small, right? If they could have proved it with 100, they would have. You see, and to put together an 18,000 trial with strict exclusions, following people for renal function, doing all of that stuff, this is huge. They spent a lot of money to do this, to go after this big market, but the differences are small. And that's why when you look at the results of the stroke rate on warfarin, it's 1.71%. 1.71. The 100th decimal point is not a mistake in the reporting. And the stroke rate on 150 milligrams of dabigatran is 1.11%. So it's a 0.63 difference on about a thing, so that's about a third less. And that's what you're hearing in the marketing. They'll of course report it not as the absolute difference, 1.7 to 1.1, but the relative difference is what's going to be reported to you. All right. Let's talk a little bit about some age issues with dabigatran. And we're going to look at abstract 3 and some of the others there. And basically, once you get age greater than equal to 75 and you have AFib, and as I mentioned, the average age in these trials is these are oldsters. At 75, the risk of ICH, intracranial hemorrhage, still is lower than warfarin, but extracranial bleeds are similar or a little higher. So there does seem to be a little bit of an age effect, so you're going to have more other bleeding problems to clean up in the really older patients. Now, when they bleed, if you jumped ahead to abstract 7, what do they say you should do? So they're bleeding from, they had a skill saw injury and they're on this. They say direct pressure. Thank you so much. Packed red cells as needed if you can't keep up. I got it. Then they point out fresh frozen plasma, don't waste your time, won't work. It's the wrong part of the why, wrong factors. They say consider PCCs, the 4-factor prothrombin complex concentrate. How many of you have that in your hospital? Some may, some won't. Consider it. This literature is moving so fast that since this chapter was put together, there have been a couple publications that suggest that considering PCCC might be where you got to go. So this moving literature on the novel oral anticoagulants also needs to change your pharmacy and therapeutics committee hospital behavior. We're having this debate right now at LA County. We need PCCC available, the 4-factor PCCC. The 3-factor won't work. You need specifically the 4-factor, the Berryplex, to reverse this if you want to have a chance. They said consider recombinant factor 7A, that's only $8,000 a dose. And then they say that if they're bleeding and they're in the midst of this drug and they've taken it or they're an overdose, the other thing that you could do is dialysis. It's dialyzable. Dabigatran is dialyzable. And so good luck placing the big lines for that in the bleeding patient. They don't tell you how to go about that little trick, but go ahead, place some big lines for dialysis in your over-anticoagulated, bleeding to death patient so you can get the drug that's making them bleed to death out of their system. Have fun with that. So there's some things about the reversal cleanup which is just not sounding good to me. Let's go to paper 4 for a second, back again. Paper 4, if you want to actually get the original manuscript, if you have any sleep difficulties, you find yourself after a night shift and you can't get to sleep, this paper is guaranteed to knock you out. It's all the gory details of the pharmacology of this drug, half-lives, areas under the curve, testing, etc. But there's some important points in papers like this that for us in emergency medicine are relevant. So the first thing they say is you can get a PTT on these patients. And if they've been taking the drug, the PTT will be up. If they've been taking the drug, the PTT will be up. However, the amount it's up has nothing to do with how anticoagulated they are. But that's still useful because go back to the child I described who just gummed up 4 tablets off the coffee table and you don't know did the kid take them or not. If that kid's PTT is normal, the kid didn't take them, which is often a consideration in peds overdoses. So if the PTT is normal, no worries. They don't have it on board. If the PTT is abnormal, you have no idea how many they took or how anticoagulated they are. Now, if you really want to know what's going on with them, the best test to do is a thrombin time. The problem is you can't get that in most hospitals, and even at my hospital, if you want to get it, you have to bow down before the gods of pathology and speak to some pathology fellow who will grumble and say, yeah, it's a send-out, we'll get you the result in a day or two. The next best test is an eccrine clotting time. I have to admit, when I saw that, I had to look it up. I wasn't familiar with the eccrine clotting time, and I think probably that's true for most of you. And so that's sort of worth knowing that the traditional tests, where we can sort of find out how anticoagulate, oh, their INR is 11, they're really over anticoagulate. No, none of that translates to these drugs. So just forget that concept. Abstract 5, the Petro study. This is a sort of a typical pharmacy paper where they do some dose ranging and they create lots of different groups. So they looked at 50 milligrams of dabigatran, 100 and 150, plus or minus aspirin. So you already got at 81 or 325, so you got like 12 groups there by the time you figure that out. And it was open label or open label warfarin, and they looked at them, they followed them for 12 weeks, and they labbed them up like crazy at 1, 2, 4, 8, and 12 weeks. And they wanted to know, this is sort of looking at safety and dosing. And so a couple things came out of this, which also may rear their ugly head for you in the emergency room, which is you've got some sick person who's on these things, and you do some labs on them, and who knows, maybe they have some belly pain or they got a GI bleed and their belly pain, and so you lab them up and you're like, I don't know what's going on here. And first off, they can have aminotransferase ALT and AST elevations occur in 1% of people on these drugs, 3 times normal. So it's not truly a drug-induced hepatitis per se, but you just need to know that ALT and AST bumps occur. The APTT levels, the PTT, which I said you can test, they did go up with increasing dose, but not in any reliable fashion. So again, this study found that, yes, a PTT can tell you they're on the drug. It can't tell you how much they're on it or how anticoagulated they are. They go up generally, but not in any reliable fashion. And then another piece of garbage, another piece of feces that no one knows the answer to that comes out in this trial, which is, so you got a person on the dabigatran who's there with some pleuritic chest pain, some shortness of breath, and a little hypoxia, and you're thinking about PE, and I described a person who's a little higher risk, but let's make it a person who's low risk for PE, and they're on one of these drugs. D-dimer levels go down as dabigatran dose goes up. So no one knows if D-dimer testing, our whole concept of ruling out PE, low-risk patient, negative D-dimer, you're done, no one knows if that's still true if they're on these meds, because the D-dimer levels go down in a dose-dependent fashion. So that's just a huge question mark hanging in the sky. Is this going to screw up if patients are on this, does it screw up all of our sort of D-dimer rationale for rule out PE? And by the way, there are already people who are at risk for clots, so PE is in the differential last I checked. So that's a little sort of shaky deal to know about. All right, let's talk about a little bit more about reversal, and I talked about it a little bit. Fresh frozen won't work. 4-factor PCC, much, much better than the 3-factor because you get the right stuff, and the 4-factor is called Kcentra, Bariplex, or Octaplex. I never understood that one. It's the 4-factor, but it's called Octaplex. If you're going to call a drug Octaplex, shouldn't it have 8 factors? I'm just asking. I mean, I don't try to get into the minds of the pharmaceutical industry too much, but you call it Octaplex, I think it ought to have 8. They say recombinant factor 7A might work, but then you're going to have the prothrombotic state that results, right? That was one of the things we learned about recombinant factor 7A when the military used it. Yeah, it stops bleeding. It turns them into a bowl of Jell-O. So if you'd like some blood to flow, recombinant factor 7A can be a problem. And so here you got a person who needs anticoagulation, who's bleeding, you reverse them with recombinant factor 7A, and now they clot. So great. Cryoprecipitate won't work. Protamine sulfate won't work. DDAVP won't work. Tranexamic acid, no one really knows. They think it might help a little if the person's trying to make and stabilize clot. Might work a little. So that's out there. Abstract 6 looks at sort of overdose settings and says you could also try charcoal in addition to dialysis, you could try charcoal hemoperfusion. And they also point out that the drugs are relatively short half-life. So say you had a GI bleeder that was on dabigatran and you could transfuse them up and get them through 4 or 5 hours, they should be out of the worst of it. So 4, 5, 6, 7 hours. Even though the half-life of the drug is 12 hours, they should come down enough that you ought to be able to not worry so much about the drug and ride them out in a non-overdose setting. A person taking the medicine as it's prescribed to them, if you can get them through their bleeding problem for the first 6 hours or so, you ought to be able to ride them out after that, because the drug levels will go down and they'll be less and less anticoagulated, assuming they have normal renal function. Assuming that. So that's kind of an interesting paper that looks at it. So that takes us through the dabigatran papers. Dabigatran, by the way, if you look up dabigatran on the web and not on the images side, you just put it in, one of the first hits will be, Sokolov and Sokolov. Has you or someone you love bled to death on dabigatran? Call our offices for a free consultation. I love when I have to clean up after drugs that already have class action lawsuits and lawyers trolling the water with the dorsal fin up. So this is one of those drugs already. But let's move on to the Zabans. So the Zabans, in terms of their generic names, like apixaban and rivaroxaban, have the word Zaban in them. And the word Zaban, X-A-B-A-N, tells you what it is. It's a 10A-XA inhibitor. Convenient. I like drug names that tell me what they are. Unfortunately, their other names don't. So they're out there. And one of the other things about Zabans is probably the Zabans, right? The direct factor thrombin 2A inhibitors, dabigatran. There's really only one of them. Dabigatran is the only one you're hearing about. And they're already getting bumped down a notch by the Zabans. The Zabans look like they're sort of winning the market a little bit. And factor 10A inhibitor antidotes exist in the world. They know about them in terms of a pharmacology agent. None of them have been brought to market. None of them have been tested. But the idea that down the road we might have a reversal agent for a Zaban is a true concept, whereas down the road there does not appear to be any direct thrombin 2A inhibitor reversal agent coming anytime soon. No one knows of one anywhere. No one's found one. No one has proved it works in some sea slug. But with the Zabans, they're already past the sea slug and they're ready to move forward to help the lowly emergency physicians clean up the bleeding feces brought to their emergency rooms. But it's not available yet. But there may be hope that the Zabans will have a reversal agent. Now, the Zabans are highly protein bound, so you got to be clear in your mind. Highly protein bound means no dialysis. So don't try and dialyze a Zaban off. It won't work. You can dialyze off dabigatran, and dabigatran also has the renal function caution, but the Zaban, no. So although we tend to lump these drugs all together, you have to know a little bit about this and know that that won't work. So abstract 8 is the Aristotle trial. It's the exact same trial that they did in the Rely trial, but for a Zaban. It's a non-inferiority trial again, where they compared apixaban versus warfarin. And guess how many patients were in it? 18,000 patients. Surprise, surprise. No mistake there. It's a little patient, a little similar. They had to get to the same big numbers. And apixaban, the stroke rate was 1.27% versus warfarin 1.6. About the same difference for the non-valvular AFib protection. And the major bleeds were sort of similar as well. Apixaban actually a little bit better. Major bleeds with apixaban was 2.1% versus 3.1% with warfarin, so a little less major bleeding. And all-cause mortality was down, and hemorrhagic strokes were down. So part of the reason the Zabans look like they're going to win this war, so dabigatran, I think its days are numbered. It's going to fade away. And the Zabans, I think, will become dominant as all those numbers are a little better. But Zabans come with their own little piece of dirt on them, which is one of those things that you're like falling asleep reading these papers, like, oh, really, really? And then you go, what? I didn't know that shit. When were they going to tell me that? So here's some shit about Zaban that you would sit up and go, what? It has a black box for neuroaxial interventions, including LP. Now, some of you are thinking, I'm always looking for a reason not to do the LP. So I'm okay with this. I'm okay with this. So you can now say, no, I am a dumb, dedicated doctor, and I didn't do the LP because of the black box on the neuroaxial interventions, and so the LP will have to be deferred to the inpatient service. But it's still a little important thing. You wouldn't want to not recognize this and then go and have someone get some spinal epidural hematoma and some cauda equina syndrome and have to cath themselves for the rest of their life. Good news, though, there'll be the polished catheters they can buy off the TV, too. And then they carry around in their pocket. I have a catheter, polished catheter, in my pocket right now. But anyway, so they'll have that available, but understand that. And so for someone who has a subdural who's on one of these, an oldster, I don't know if any of you have ever seen an oldster who fell and had a subdural? So they can't really operate on them, right? They're now condemned to sort of a non-op management. I don't know what the neurosurgeon's response to that's going to be. So that's, I can imagine a lot of kind of sticky, smelly poo being stepped in around that. So that's sort of worth noting, that there's no dialysis on those. So conclusions about this topic. The novel oral anticoagulants, it's a fast-moving market. It's a fast-moving literature right now. Reversal concerns are prominent for emergency physicians. I have no doubt in our mind that a couple years from now, many of us will have found ourselves in very sticky situations surrounding these drugs. I can see you tapping an altered patient, not knowing their meds, and then them having a problem and finding out afterwards. Well, they were on Zaban. Didn't you check the old computerized record and drag the pharmacy net? Like some forensic scientist team looking for the fact that they were on Zaban? You cavalierly went ahead and punctured their bleeding spinal canal? And now they're, so I can see lots of sticky situations arising from these. And so I think these need to be on your mind. I think that we all need to be pushing harder to make sure that we have Bariplex or one of the 4-factor prothrombin concentrates out there. Now, a couple other things, not in your chapter, just some things that I looked at that were recently out there. So remember Plavix, the old days with, Plavix still around, but remember the residents called it Bleedix because there were some problems with Plavix. And I don't know if any of you saw this, but I saw lots of patients on Plavix who they were on Plavix and then their urologist wanted to do some TURP on them for their prostate or something, some relatively minor procedure. And so they said, stop the Plavix, and then before they could do their prostate biopsy or their TURP or their whatever their thing they were going to have done, they stroked out. Like, geez, well, I guess the good news is they don't really care about the prostate anymore. The bad news is they've stroked out. And so, important warning, this one just came out recently, stopping treatment with dabigatran increases the risk of strokes and blood clots. And this is about rebound. So many emergency physicians, although the rebound phenomena was never clearly described or quantitated for Plavix, a lot of us kind of knew because we'd seen enough that these puppies bounce back. This is a drug where, one, you have to take it for life, and God damn it, you have to take it for life. If you stop, you'll be screwed. You'll stroke. There is a suggestion that with both the Zabans and dabigatran that this rebound exists. This one specifically addresses dabigatran and was in Medline Plus. And so an important warning about this possibility of rebound hypercoagulable states with these. Again, when you mess with the Y is finicky. You mess with the Y, you're going to have a narrow therapeutic index. So that's one of the issues. And then there have recently been a couple of case reports. There was one little series that said that PCCs, the prothrombin concentrates, worked for one group but not the other. Then there was another paper that said, no, they worked for that group too, and they successfully reversed the guy and he stroked out. But they said it did reverse him. It did reverse them. We didn't like where he landed on the spectrum of reversal, but it reversed him. And so you're going to have to follow this carefully to find out, exactly what to do. When you read about these drugs, they raise easily as many questions as they provide answers. Might they be an advance for the AFib population? They probably are. Am I eager to see this drug expanded to things like ACS and CHF and a whole bunch of other things? Not really, not until we know what we're doing. I'd like someone to be thinking urgently about the emergency physicians out there faced with bleeding. I'd love to know that they were like working hard on that 10A reversal agent. That would make me feel better if they could just tell me, no, we're on it. We're really worried about this. Some statement like that, even if it wasn't true, would make me feel better. But I see us as emergency physicians faced with a fair amount of cleanup for these drugs. I feel like this drug has been released on the public with aggressive direct-to-consumer advertising without much knowledge of what the cleanup's going to look like.